Buenos días a todos. Vamos a comenzar ahora el segundo día de estas sesiones. Ayer fue un día fantástico y hoy yo creo que vamos a seguir por el nivel o incluso mejorarlo. Eh, no les voy a decir nada de nuestros ponentes. Ahora se va a encargar el doctor David Lobo. Como ayer les contaba, él es rinólogo en el Hospital Marqués de Valdecilla, compañero mío y hoy va a llevar una sesión con ponentes tanto de Australia, Nueva Zelanda y México, o sea que por eso es la hora en la que estamos comenzando y creo que les va a gustar mucho, así que sin más le doy paso al doctor David Lowe.
Thank you very much, Jaime, for this presentation. I think you are coordinating an excellent course, and well, let's hope today we have a very nice session as well. So, good morning, good afternoon, good evening, good night to all of you who have connected live from the 5 continents. Welcome to this online session on maxillary sinusitis. Today we have an excellent panel featuring 3 of the most esteemed experts in the field of rhinology. I would like to express my gratitude to the sponsors, GlaxoSmithKline and Sanofi, for the support of this course, as well as to the Valdecilla Research Institute, IDIVAL, for providing us with a platform to discuss our shared interest, rhinology, within the series of conferences, excellent conferences they organize throughout the year. And I invite you to follow them. Special thanks go to Jaime Viera for inviting me to help him organize this course and also for offering me the opportunity to moderate one of the roundtables. He challenged me to select the topic and the speakers, and I trust you will like the selection very much. So I'm gonna share just a few slides, a couple of slides. The subject we're discussing today, maxillary sinusitis, has gained a lot of attention in recent times, with covering different surgical techniques, the pathophysiology and the microbiology. And especially, particularly with connection to recalcitrant infections and odontogenic sinusitis and complications. And I'm so happy to have such wonderful speakers today. So this is the program we have today. First, I would like to introduce Professor Alkis, whose extensive research has been instrumental in shaping current clinical practices and has significantly advanced our understanding and techniques in maxillary sinus surgery. Professor Alkis is a current president of the Australian and New Zealand Rhinological Society and chairman of otolaryngology, head and neck surgery at the Queen Elizabeth Hospital in Adelaide. He has authored over 250 peer-reviewed journals and more than 20 book chapters, and he has delivered hundreds and hundreds of national and international presentations. He's a wonderful speaker. And he also co-heads an active research department at the Basil Hetzel Institute, researching causes and treatments for sinusitis and skull-based tumors. And he also serves as the board of training for the Australian Society of Otolaryngology and Head and Neck Surgery. Next, we have Dr. Raymond Kim, a distinguished expert in chronic sinusitis and rhinology, with numerous publications in leading journals. Dr. Kim is an academic rhinologist at the University of Auckland, New Zealand. He earned his PhD in the microbiology and immunology of chronic rhinosinusitis and completed his fellowship at the Stanford University in the United States. And currently, he continues his research on the pathophysiology of chronic rhinosinusitis with a special focus on microbiology, biofilms, and disease progression. And also, he is very interested in sinus and nasal anatomy and education and surgical training. And finally, we have Dr. Luis Fernando Macías. He's a leading expert in anterior scalp-based surgery with innovative techniques and extensive experience, which continue to inspire and guide practitioners worldwide. Dr. Macías leads the rhinology and scalp-based surgery department at Hospital Mexico Español in Mexico City, where he also serves as an assistant professor of otolaryngology, head and neck surgery in La Salle University in Mexico. He completed an advanced rhinology training in Vancouver, Canada, and also in Adelaide, Australia, after his residency. So for me, it's a really privilege to have such distinguished colleagues here to share their insights. And our session today promises to be both insightful and engaging as we delve into the latest advancements of maxillary sinusitis and the surgical techniques to treat the maxillary sinus diseases. So I'm really, really happy to have this panel of experts today to share their insights. I'm sure that we're going to learn a lot today, and I'm just looking forward to listen to them. We'll begin with an overview from each of our experts. Then we proceed with a Q&A where we will welcome all your questions and comments. But before we begin with the presentations, I would like to share a clinical case that may help to illustrate all the topics that we'll be discussing today. I plan to do this after the end of the session, but as Alkis has to leave before, I will present it now. So just to give him the opportunity to share his insights before his departure. So, well, this is one of my patients I attended last year. She's currently doing quite well. She's a 65-year-old woman, non-smoker. She was diagnosed with urticaria and angioedema due to amoxicillin sensitization in 2003. So she went to her GP several times. She was also attended at the emergency department on several occasions. And the patient reported the occasional swelling between the eyebrows and eyelids persisting for approximately 1 year. On the nasal endoscopy, she had a mucopurulent drainage in both middle meatus, and she had also received antibiotics, nasal corticosteroids, and oral corticosteroids. So I'm gonna show you the CT scan. So in the CT scan, we can see a complete opacification of the left maxillary sinus with an inflammatory remodeling of the medial wall with thickened sinus mucosa and blockage of the osteomeatal complex, with inflammatory involvement of hypoplastic frontal sinuses showing signs of chronic periostitis. And there is a right parasagittal bony defect in the anterior cortex, accompanied by signs accompanied by renal subgaleal inflammatory component. So with the initial diagnosis, I'm going to show the sagittal as well. With initial diagnosis of a Potts-Puffy tumor, I would like to ask the panel of the management of these patients. So I would like to raise these questions, these key discussion points for the symposium. So which will be the best medical therapy regarding to antibiotics, corticosteroids, and the appropriate timing and duration of treatment? What could be the potential surgical interventions and surgical approaches? Are there any anatomical challenges highlighted by imaging? What could be the appropriate time for dental assessment? And finally, what would be your strategies for improving post-surgical outcomes and reducing recurrence? And well, with that, I'm pleased to leave the floor to Alkis Psaltis, and what is it's going to be an excellent, insightful presentation. And well, just let us start off. Thank you, Alkis.
Thank you, Dan. What I thought we do is let's do the case first. If you can put up the coronal images again, because I think there are two really important things that I've noticed on this case. First of all, I think the fact that you have a loss of the cortex of the frontal bone shows that the patient does have a complication of sinusitis. And as soon as a patient has a complication of sinusitis, it really is a surgical problem that needs to be corrected. And this patient needs urgent surgery, in my opinion, with intravenous antibiotics to drain the acute infection and open the sinuses up. Because once you start getting erosion of the bone, you probably have a very, very pathogenic, virulent organism. So the surgery that I would do in this individual would be a drill out. They have very small frontal sinuses, but those sinuses are going to stenose in the presence of a very significant pathogenic organism. And really what we're wanting to do for this individual is open the sinuses maximally to get a culture, to drain the infection, and then to facilitate ventilation of the sinuses, plus penetration of topical antibiotics. And although the evidence for topical antibiotics is limited in the literature, these are the patients that I think benefit from it, because you can saturate the sinuses with very high levels or high doses of an antibiotic that wouldn't be tolerated systemically. In addition to this, I'd have the patient on intravenous antibiotics. So that's the first relevant point. The second relevant point is that there seems to be something going on in the floor of the left maxillary sinus. And what I would like to know is, has this patient had any dental issues? It looks like there could have even been an attempted maxillary sinus lift in that location, because that could have been the source of all of this to start with. And so treating the offending site of origin, either with a dental extraction or cleaning out that infected sinus lift, will be very important so that the infection isn't perpetuated by that ongoing source. So they're really the two important things off the glance. They've got a complication. We have a possible cause being that left sort of dental issue. It needs surgery, intravenous antibiotics, and it needs, in my opinion, high dose topical antibiotics to saturate the sinuses. And really the therapy will be determined by what we culture and how the patient heals. And so this patient needs close attention, very frequent debridements, to ensure that we're not stenosing those frontal sinuses and the maxillary sinus. I'd have a low threshold for a modified medial maxillectomy, and I'll discuss this in my next presentation. But they're the salient points, I believe, Dave.
Thank you very much. I think I don't want you to lag too much because you have to leave. So you can, if you want to go with your presentation, we leave other comments at the end if the next speakers want to comment on the case as well. But thank you very much for your comments.
Thank you, Dan. First of all, thank you very much to Jaime and to Dav for letting me present today. It's my indeed honor and my pleasure to be here. I wish my Spanish was better than it is so that I could do this speech in Spanish. But essentially what I'm going to be talking about is maxillary sinus surgery. And I think this sinus is often neglected as an easy sinus, and we often leave it to the most junior registrar to do the maxillaries. But in actual fact, it's a sinus that needs close attention with good surgery to prevent poor outcomes and complications. So these are my disclosures. None of these disclosures are relevant to today. I also post my presentations on the social media platforms and interesting cases if anyone's interested in further learning. So essentially, I'm going to be speaking to you about my staged approaches for inflammatory disease. I don't do the same extent of surgery for every maxillary sinus. I do it determined by how much inflammation we have and my evidence behind this. I also want to speak to you about two other topics, which will go less than 30 minutes, about silent sinus syndrome, and also how we can also do other approaches for diseases in the sinuses that may not necessarily be inflammatory. So the question is, should we be doing the same surgery and the same extent of surgery for each of these three patients? We can see in the first patient, we have some thickening of the perimeter of the sinus. We have obstruction of the ostomeatal unit, but generally we have good aeration. In the second case, the thickening is more progressed. We have a bit more ethmoid sinus disease. And in the final case that we can see here, we have considerable opacification of the sinuses. Now, what we do know from the literature is that the extent of eosinophils that we have peripherally in our blood and also in the tissue of our patients in the sinuses correlates to the severity of disease. And so the more of these eosinophils we have both peripherally and locally, the more patients are going to have inflammation both preoperatively on CT scans and endoscopy, and also postoperatively. So inflammation not only correlates with preoperative burden of disease, but also with how well these patients do after surgery. And what we know is that irrespective of the underlying cause, whether it be bacteria, whether it be an aberrant immune system, biofilms, fungus, whatever it is, this creates a significant inflammatory load. And this inflammatory load will drive the inflammation within the sinuses. So if we look at the eosinophil, which is responsible for a lot of the disease we see in Caucasian patients, has a lot of functions. It not only presents antigens, but it also elaborates a cytokine response to those antigens. And what it does also is it attracts other eosinophils, which can exaggerate that response. And with time, we not only get release of eosinophilic cationic protein and other cytokines that injure the tissue, but we get irreversible remodeling, which makes these patients steroid resistant. And because these patients have a lot of eosinophils, this can create a cycle where the inflammation is perpetuated by disease if we don't get as much of that inflammatory burden out at the time of surgery. So what I say is this patient with pus in the sinus is very different to this patient with thick eosinophilic mucin, and is very different to this patient as well. And these patients all need to be considered differently in terms of how much surgery we do. So for a patient with grade 1 disease, and I call grade 1 where we have a little bit of thickening of the ostomeatal unit and very minimal thickening of the sinus, I simply do an uncinectomy. And this is the technique. It's a swing door technique where I'm trying to remove the vertical portion of the uncinate as a whole. And you can see I'm using a 30-degree scope, and I'm dissecting out the bone of the horizontal portion without really opening the sinus significantly wide. Because in these patients, if we can get good mucosal preservation and we can get mucosal to mucosal apposition, these patients will do extremely well and the disease won't recur. In a patient who has grade 2 disease where the inflammation is a little bit more, I start obviously with the same procedure, doing the uncinectomy. But in these patients, we have a moderate inflammatory burden within the sinuses. And so in these cases, I'm going to open that antrostomy more extensively. I'm going to open it posteriorly so that I can get my instruments right back to that posterior wall. And here you can see the considerable amount of pus we have sitting within the sinus. And the reason why I'm opening this sinus more broadly is because there is good evidence to show that the extent of the antrostomy correlates with the amount of access you have postoperatively to steroid irrigations and steroid topical antibiotics. And it's really going to be these two treatments that are going to keep the inflammation at bay. Doing a large antrostomy also allows us to access with angled scopes the majority of the sinus and to suck out as much of that pus as we can to get the appropriate swabs that are needed. We're now dealing with a patient with complete opacification of the sinuses. So these are patients often with underlying ciliary defects, patients with fungus, patients with cystic fibrosis. These patients have a significant inflammatory burden. They have a huge extent of disease, and they need to be treated with more modified procedures. And so really I categorize these two patients into those with a very high inflammatory load or those with poor mucociliary clearance where they can't naturally clean their sinuses out due to their cilial defect. Now with these patients, if you do, sorry, I'll go back to that slide. If you do simple maxillary antrostomies as a primary procedure, you often get a repopulation of disease. And here you can see that this patient has had a very good surgery performed. They've had the unsnet completely removed. They have wide antrostomies, but they have still a significant burden of disease. And the reason for this is because much of the disease was left behind at the initial procedure, purely due to the fact that we couldn't access the inferior or the anterior aspects of the sinus. So there have been studies to show how much of the sinus can be accessed with angled instruments. And in this particular study, it showed that with a 30-degree scope and slightly angled instruments, we really can access about 30% of the sinus. With a 70-degree scope, we can access probably 60 to 70% of the sinus, but still the parts that are very, very difficult to access without making the antrostomy any bigger than to the floor of the height of the inferior turbinate and the posterior maxillary wall, we really can't access the inferomedial or anterior medial portion of the sinus. And so what happens with these patients is we do our antrostomy, we leave residual disease behind, and we can see that in the floor of the sinus. And what we're leaving behind is a high burden of inflammatory cells, prime T cells and eosinophils. And with time, those cells, through that cycle that I produced and showed you before, will repopulate the disease process. And so 6 months down the track, these patients will recur with ongoing disease. And so these patients really need extended surgery. And there are two approaches that you can do for these patients. One is the canine fossa-trephine, which used to be more popular probably 10 to 15 years ago. And my favorite would be the extended maxillary antrostomy or modified medial maxillectomy. So if we look at the canine fossa-trephine, there was a kit available from Medtronic that's no longer in production. But essentially, this aimed at creating an antral window similar to a caudal luck, and the anatomical landmarks were the mid-pupillary line and the nasal seal or the nasal floor. And using these landmarks, in the vast majority of cases, you missed the infraorbital nerve trunk, and these patients didn't get any side effects. Here you can see that through the antral window, you can rapidly access the majority of the maxillary sinus, including the very difficult to reach inferior and anterior aspects. And this is a video of this patient that I showed you and how the canine fossa-trephine is performed. You do an antrostomy as a beginning of every maxillary sinus surgery. And in this case, you can see that we're using the kit to raise up the buccal gingival mucosa. That's the front face of the maxilla there. And then after doing this, a drill bit is used to penetrate the bone and to access the sinus. And this then allows the shaver to go into the sinus through this very small window. And through the actual endoscopy, we can remove that thick inflammatory burden and that thick inflammatory milieu. So we can remove that inflammatory burden. And these patients do extremely well. This procedure is quick, with very minimal morbidity, and the scar heals very quickly. Now, there has been some, and this shows you what it looks like post-operatively. Now, there have been some studies done, and these were the early studies, which showed that if you just simply use the landmarks of the mid-pupillary line and the nasal floor, that there was a 76% complication rate. Now, most of these complications were very minimal, soft tissue swelling, but 10% of these patients did have some facial numbness, and this can persist beyond 6 months. And for this reason, the group, PJ's group, revisited it and saw whether or not they could reduce the complications by changing the technique slightly. Now, the reason why these patients had complications is that because in the vast majority of patients, if you use purely anatomical landmarks to guide you as to where you make your entry into the sinus, you miss the maxillary, the infraorbital nerve, the main trunk. But this isn't a universal distribution of this nerve. Although 90 to 95% of patients have this distribution, there are some patients, 5 to 10%, who also have ramification of nerve branches off the main trunk, which pass through those anatomical landmarks that I spoke to you about earlier. And you can see that there are different branching patterns. And if you had the second or third options, and you just use the anatomical landmarks, these are the patients who will get numbness and 6 months of symptoms. And so in order to reduce this, they actually introduced the endoscope. So rather than just relying on the anatomical landmarks, an endoscope is inserted, and then you can readjust the entry point depending on where those nerve branches are. And here you can see the nerve running through where we would ordinarily place it using the anatomical landmarks. And here we've modified it by slightly putting it off to the side so that we miss that nerve trunk. You have to be extremely careful in this case that you don't hit the nerve, the teeth roots, because that can also cause complications. And by simply using an endoscope to guide you, you reduce the complication rate and the nerve numbness down significantly. Now, there have been long-term studies to assess disease control, and it does show that these patients remain disease-free in the vast majority. And even in patients with very severe disease, such as Samter's triad or aspirin-exacerbated respiratory disease, their chance of recurrent disease is much less than a standard medial antrostomy. Now, do we have other options? Well, this is my preferred option, and I'll go through the details why. So we have a similar patient. This patient has fungal sinusitis with thick eosinophilic mucin. And in this patient, we're going to do an extended antrostomy. So the first part is to identify the natural opening, the ostium. This patient's had previous surgery. So we want to know that because that's going to guide where we place our instrument. So here we're using a curved artery clip and we're directing it towards the natural ostium, but we want to preserve the head of the inferior turbinate. And the reason we do this is so that we can get some ongoing humidification after surgery. We then resect the mid-third of the inferior turbinate, and I like to do flaps because these flaps will cover the exposed bone at the end of the case so that we don't get crusting in the postoperative period. So I raise an inferiorly based floor flap, and then using a freer, because this bone is often soft, we can punch through at the level of the ostium. I don't come any further anterior to that at this stage. We simply fracture the medial maxillary wall. We remove the bone here, and then you can see we can then start to deal with the disease process. And using angled instruments, we can get this very tenacious, thick fungal mucin, which ordinarily cannot be removed through a standard antrostomy. You can see how viscous it is, how it really doesn't want to break up. In order to increase access, we can use a heavy backbiter below the nasolacrimal duct. And if we are only going 2 widths of that backbiter, we can avoid the nasolacrimal duct, and then we can access the anterior aspect of that sinus, and it's very difficult to reach anteromedial, anteroinferior component. So here you can see by doing that extended approach, we've able to remove more of that disease process than we could have otherwise. And so we're giving this patient the best chance for topical therapies to work. And you can see with the 30-degree scope, we can see all aspects of that sinus. We can see the anterior inferior wall. Really important to cauterize the inferior turbinate, as this is where the vascular bundle sits. I try to avoid monopolar because that will cause crusting. I've now modified my technique from this video that I really try to cover all of this exposed bone at the end of the case with mucosa, and these patients get much less crusting as a consequence. And this is the post-operative cavity, and we can see that we can actually see right up into that sinus, and we can actually clean the sinus out post-operatively as well. Now, we did look at the results of this approach. This approach was first described by 2 of my previous fellowship mentors, Peter Wang at Stanford and Rodney Schlosser in South Carolina, and both of these showed all of the patients that had these procedures had an improvement, with most having a complete resolution of their disease. As I said, this was also done by one of my other fellowship directors who had similar results. Everyone improved, with the vast majority showing no ongoing disease 3 years down the track. Now, when I was at Stanford doing the fellowship, we looked at these patients long-term. And so we did a phone interview with patients 7 years after their initial procedure. And we found that the improvement rates were comparable to what was seen in the first 12 months. So really, we have ongoing disease control in these patients, symptomatically and endoscopically. So what are the differences between the two? Well, the canine fossa is very quick. They get less post-operative crusting because you're not having as much of that bone exposed at the end. The downside is that you can have facial numbness and facial swelling, and you can't really access that cavity nicely post-operatively if you want to clean out a bit of fungal debris that has returned. With the extended approach, underneath the head of the inferior turbinate, the procedure does take a little bit longer. You don't need to purchase any equipment, and that equipment's no longer available, and you do have less long-term complications. So my standard of approach now is the extended maxillary antrostomy. So moving on to other two pathologies that I think are worth discussing when we discuss maxillary sinus. Here we can see silent sinus syndrome. Now, silent sinus syndrome is essentially an asymptomatic contraction of the maxillary sinus due to negative pressure. As a consequence, we end up getting descent of the orbit. And some people think that you need at least 3 millimeters of descent or enophthalmos in order to actually classify it as silent sinus syndrome. It can be confused with chronic maxillary atelectasis, which is contraction of the maxillary sinus. The difference between the two is that chronic maxillary atelectasis actually occurs in the presence of other sinus symptoms. But in actual fact, they probably represent a continuum of maxillary sinus disease. And just recently, a group from the US consolidated both of these two conditions into a continuum of maxillary sinus contraction. And so they looked at all of the literature published on silent sinus and chronic maxillary atelectasis and found that there was so much confusion that we needed a new classification system. And so this group looked at classifying them from 1 to 3, A to B, depending on whether or not symptoms were present or absent. And really that silent sinus syndrome that I was speaking about correlates to stage 3A, which is where the patient has a clinical deformity, namely enophthalmos or descent of the orbit in the absence of symptoms. But in actual fact, it probably represents a spectrum of disease processes. How do we deal with these patients? Well, it's really, really important that we recognize this preoperatively. And the reason for this is that the uncinate process is contracted and pushed up against the orbit. So in this patient, we're doing a septoplasty. We're doing a pushback technique to remove a large spur. We're now seeing that this technique doesn't create too many holes in the septum. We're now accessing that right maxillary sinus. Here we can see the contracted sinus. Now, I would caution against using a sickle knife to do a cut because you're cutting onto orbit. So simply what I like to do is palpate the free edge of the uncinate process, use a backbiter, and then very, very gently tease the uncinate process off the orbit. I then use a through cutting instrument, no powered instruments at this stage, to access the ostium. Mucosal preservation is really important here because you don't want any trauma to the surrounding bone because the orbit's just above you, and you want to have this stay open and be ventilated long term. So here you can see very mucosal preserving techniques. Now that we can see the orbit, we can suck out the very classical glob of mucus, which is almost seen invariably, very thick, tenacious mucus in these silent sinuses. And then we can tidy up with a shaver pointed in the inferior direction. So you can see really very minimal tissue trauma. We want to keep this very closely approximated so that we don't get any scarring of that ostium, so that this sinus stays ventilated and the inflammation doesn't recur. And that's why I remove the bone and I then shave the mucosa just so that we get mucosal to mucosal apposition. So I really want to speak only about the final two approaches when considering the maxillary sinus. in the last 5 minutes of this talk. We've got the pre-lacrimal approach, and we use this when we're dealing with lateral-based pathology or anteriorly based pathology. Here we have a patient with an inverted papilloma. This patient had 3 previous surgeries prior to seeing me. And essentially, the reason why the patient recurred was that they had the attachment site left unaddressed at the 3 previous procedures. Here we can see that it's very difficult to access that anterolateral attachment site through a standard antrostomy. And essentially, these are the indications for what I do, the pre-lacrimal approach: inverted papillomas, juvenile angiofibromas, and anything in the infratemporal fossa that we want to. This is how the approach is done. We described this in 2016. Other people have also described it, and there are a lot of modifications of the technique. But essentially, we raise a mucosal flap over the inferior turbinate. We identify the piriform aperture. We then remove the bone just behind the piriform aperture so that we don't get notching of the aline crease. We identify the nasolacrimal duct. We remove the bone in front and behind the nasolacrimal duct, and we create our antral window and then reapproximate the mucosa. Of all the techniques I've described, this is the most physiological preserving technique because the whole inferior turbinate is preserved and humidification can occur. So this is showing you how we do the technique. I've made a few modifications since this first video that we performed, but essentially what we do is raise a flap. I now just do a vertical incision. I don't do an L-shaped incision. I think this is much easier to close. In the past, I would really identify that piriform aperture. Now I don't raise the mucosa over it because we do have some branches of the inferior alveolar coming out. So that you can get some numbness. But here you can see through that pre-lacrimal window, we can identify that lateral attachment, and then we can drill the lateral attachment right down and cauterize it so that we don't get recurrence. We can also do a pre-lacrimal approach for nasopharyngeal juvenile angiofibroma. And here you can see that we have very good access to that infratemporal fossa through this technique. And here we are identifying that pre-lacrimal bone. We can resect it. It naturally fractures around the lacrimal duct because that's the natural dehiscence or weakness in the bone. And here you can see we can now use that window to access the sinus. If you combine this with a transeptal approach, you have really good access to all aspects of the infratemporal fossa beyond the infraorbital nerve. And here you can see we're using the kerosene through the pre-lacrimal window. We're using the suction through the septal incision. We can identify the juvenile angiofibroma, ligate the artery, and resect these tumors quite easily. So it's a nice modification to do whilst preserving function for these patients. And here you can see we're now dealing with the Vidian component, which is always very important. It's thought to originate from this area, and this needs to be addressed so that the patients don't get recurrences. So obviously this isn't about juvenile angiofibroma, so I won't go through this video much more, but it's just to show you the techniques. You can also do septectomies. Another approach that should always be considered when you've got very large juvenile angiofibromas is the transantral approach. So this patient, there's no way that you can access this tumor through the nose ipsilaterally. And because it's prolapsing through the nose, you really need to try to gain access through an antral window. And so in this patient, we went back to doing the canine fossa. Here you can see buccal incision, raising the mucosa up. We're using a Raytec to free up the soft tissue onto the bone. And here I'm using an osteotome to enter the sinus. And this will allow me to then identify through the transantral window the posterior maxillary wall. We remove the bone. We identify the internal maxillary artery. But this is where this technique becomes very valuable, because having identified and clipped the artery in this particular case through this transantral window, we can then perform a retrograde modified medial maxillectomy from within the maxillary sinus. And by doing this, we're actually creating room to retract this tumor into the maxillary sinus and then to perform the surgery. So through that modified medial maxillectomy, which has been done from inside out, we now have access to the tumor and can compartmentalize that tumor. So really the take-home points are, think about the extent of disease for which you're dealing with it, do the appropriate surgery, don't be scared to do a primary extended approach if the patient has a high burden of disease, fungus, or mucociliary dysfunction. If the patient has secondary, has a high burden of disease and has failed, your extended modified medial maxillectomy or magorantrostomy should be performed so the patient doesn't recur. If the patient has anterolateral disease, a prelacrimal approach is very easy to do and should be considered. So on that note, I thank you very much for your attention, and I'm happy to take any questions in the last few minutes.
Thank you very much, Alkis, and thank you very much for sharing this frightening case of juvenile angiofibroma. It's fantastic how you could deal with this case. But maybe Raymond Kim or Jaime Vieira or myself can ask you some questions. I would like to know about the prelacrimal approach. If you make any difference with the surgical technique when you deal with type 2 or type 1, type 2, or type 3 nasolacrimal tract?
So that's a really good question. And obviously, the bigger the prelacrimal window and the bigger the space between the piriform aperture and the lacrimal, the easier the prelacrimal approach. In the past, I tried to avoid doing prelacrimal approaches for type 1, where I didn't have a prelacrimal window. But with the modification of the technique, where I make an incision quite high up, almost to the ascending process, right down to the floor, below the inferior turbinate, I think you can create a window in all cases, because you're going in those type 1s where you don't have much pneumatization. You can go in underneath the inferior turbinate and gain your prelacrimal window that way. So really, that's been my biggest modification, Dav. In the past, I did these L-shaped incisions. I find them very hard to close because the mucosa is very thin, high up in the lateral nasal wall. You often tear. With these straight vertical incisions, it's a robust sort of flap, which often you don't need to stitch at all. It will stick down with a bit of Surgicel. So I don't actually suture anymore either.
Okay.
I have a very low threshold to take inferior turbinate bone too. I will take that commonly and leaving the mucosa of the inferior turbinate behind.
That's awesome. Raymond, do you want to make any comments or share any insights about presentation?
No. I guess topical antibiotics, do you presumably culture directed, but do you have a go-to for CRS disease, or do you use it very depending on the pathophysiology?
So I won't start topical antibiotics without a culture because you don't want to promote resistance. I mean, Staphylococcus aureus is the most common. So topical mupirocin in a concentration of 0.05%. We did some work on it. So we actually worked out the dose in vitro to kill staph biofilms, well, to reduce staph biofilms. We use twice daily washes for 2 to 4 weeks. We found that in those patients, you could achieve culture cure in 90 to 100%. But all of these patients had recurrences with a mean recurrence rate around 174 days. So you're not curing the biofilm, you're reducing the burden and preventing persistent colonization. For Pseudomonas, I use topical tobromycin. For Haemophilus, and we're finding Haemophilus tends to be quite persistent and create quite thick, sticky white secretions. These patients do really well with levofloxacin. So I use levofloxacin for patients with Haemophilus. For patients with Staph lutegenesis, which is an emerging staphylococcal virulent species, I use topical vancomycin. But I always want a culture-directed antibiotic. I tell the patients I'm not curing them, but I'm giving them about 100 to 170 days of not having crusting within their sinuses.
Yeah, I agree. It's really important. the case I shared before, the patient, she had allergy, you know, to amoxicillin, so also beta-lactamics, you know, probably she needed to repeat the allergy test, no, because a long time passed since she had that allergy reaction. And well, the cultures grow a Streptococcus aeruginosus and a Streptococcus intermedius. So it was really important to know about the sensibilities or resistance of the, you know, the bacteria, no, implied.
And
I
Dab,
have
I would
a
also
Okay.
say, Dab, they're odontogenic pathogens. So Streptococcus aeruginosus, or Streptococcus malariae, it's also called malariae, is an odontogenic pathogen. So that gives you a clue that
Yes,
too
yes, of course.
needed to be addressed. And
Yes.
probably, do they do a sinus lift in that case?
Yes. No, I talked to the dentist from the first visit, and
Yeah.
I wanted to know what how you deal, no, with this timing, and no, and what's your relation with the dentist or even with the maxillofacial surgeon, no, sometimes.
Yeah.
Did that graft
So,
survive?
pardon?
Did that composite, they probably put some composite up there, did that survive? Did they need to dig that back out?
At the back out. Well, she had the dentist appointment. She revised all the, and although you could see the CT scan, there were a lot of filling, no, in the floor of the maxillary sinus. The dentist thought was everything okay. So, well, at least she revised the dentist revised the patient from the beginning and after treatment, and well, he's currently checking, and the patient is doing well. So yeah, surgery and antibiotics did also their work.
Alkis, I have a quick question about inferior turbinate reposition. Is something that you do when you do extended medial maxillectomy, or do you think just preserving the head, the mucosal head of the turbinate is enough?
That's a really good question. I like the reason why I do remove it and I keep it removed is because I want to access that cavity post-operatively. We also published another study in 2019 which looked at the amount of disease you could remove, as well as post-operative irrigations. And doing the extended approach, we graded it 0 to 5. 5 is where you come beneath the head of the inferior turbinate. 4 is where you just come to the floor, but you don't remove any of that anterior part. You do increase exponentially the amount of irrigation that can get into the sinus and keep it clean. These patients, often if they've got cystic fibrosis, have non-functioning sinuses. So you're trying to allow gravity-dependent drainage into the nasal cavity, and that's why I leave it open. If you preserve the head, I've never had a case of empty nose syndrome, and I do preserve more of the posterior part than I used to. So I'm really just resecting the middle third now, Amy.
Okay, thank you. I tend to do the same. I think I'm only doing this reposition in kids with recurrent antrochoanal polyps, but in other pathology, I just tend to do the same that you're doing. Thank you, Alkis. Amazing presentation as always.
Thank you so much.
Well, I think we can move now to the next speaker, Raymond Kim. So thank you again very much for being here, and is your floor.
Thank you very much for the opportunity and the invitation. So I'm speaking from Auckland, New Zealand. There's no conflicts to declare, which is way over here. And actually, if you look at the globe, I'm right underneath you on the other side of the globe. So hello from Auckland. I also am part of the Australian New Zealand Rhinologist Society, where Alkis is president, myself being the treasurer, and we're holding a great conference next year in New Zealand. If you'd all like to come, and I'll give you a little bit more detail about that later.
Thank you.
So really going back to the microbiology differentials, which is the topic I've been given, there's something that's turning these patients into something like this. And yes, maybe it's eosinophilic inflammation, but there are plenty of patients who would do surgery and then we still see crusting and issues going on in the maxillary sinus. And this sort of chronic maxillary sinusitis is what we're talking about. And really, we need to start talking about not just bacteria, but all the different microbiome and the pathogens that we're living with, including commensals. And to really simplify things, because I don't think there's any need to make it more complicated than it needs to be, these are the sort of 4 categories that we think of. And just to get the parasites out of the way, because they're very uncommon, you know, we can get roundworms and amoeba and different pathogens in the sinuses, but the other 3 are the main pathogens that we're talking about. And so some sort of an antigen, whether it's virus, bacteria, is coming onto the sinus mucosa, causing some sort of an inflammatory response. And it might be eosinophilic, neutrophilic, and that's driving this inflammation. And it's like there's a constant balance and battle between the innate immunity and what we're breathing in. And at some point, there's a winner and a loser. And then it might not be just one antigen, it might be virus, bacteria working together, or fungi. And there's an interaction between the microbes and within the innate immunity, which makes the disease process a chronic inflammatory condition. And if we think about viruses, you know, there's the whole common cold, and all the viruses that we know of, which can cause a viral sinusitis or viral mucosal edema, which then cause a bacterial sinusitis in an acute setting. And yes, we might be able to do PCRs and viral cultures, but in a common cold, we're certainly not going to go down antiviral pathway usually for sinusitis. Which leads on to bacteria, and we know this is Robert Koch, the German biologist, microbiologist, who basically described, look, if there's an infection, you culture it, plate it out, and that's the pathogen. But really, it's more complicated than that. Yes, there are some differentials for a typical acute sinusitis infection versus chronic rhinosinusitis, but this is not really the entire story. For example, if we see somebody who presents like this with mucus recirculation, who's complaining of postnasal drainages, and there is some thick mucus that they're producing, we will culture bacteria, but that doesn't mean that it's an infection. That doesn't mean they necessarily need antibiotics. So we need to be thinking about bacteria as beyond just culture, thick mucus, give antibiotics. And it's because bacteria lives in very different niches. I mean, there is the planktonic bacteria. There would be bacterial biofilms, which we've alluded to already. There's actually bacteria within the epithelium and even within the tissues. And we set out in our group to try to look for inflammatory cells immediately underneath the biofilms versus somewhere a bit more distant from biofilms, to see if there's a difference in the inflammatory cells underneath the biofilms when we were initially studying the potential pathogenic cause or role of biofilms. And then we came across these colonies. So you can see a bacterial microcolony there within the tissue. There's an eosinophil, a few macrophages, but really there's a whole area around this bacterial microcolony that's not inciting an immune response at all, because, you know, we'd think that if there's bacteria in tissue, it might act like a microabscess and cause inflammation, but clearly these colonies were living there quite happily. So if we see bacteria in tissues, is that something we need to treat? Is that the drive of the chronic maxillary sinusitis? We try to characterize this. So the whole idea was, if there's surface bacteria and if there's bacteria in the tissue, were they the same or the different? For this particular paper, we really focused on Staph aureus, because we talk about how Staph aureus culture at the time of surgery can lead to worse outcome, how staph is often cultured in the chronic infective patients. So we did mucosal swabs at the anterior nares, middle meatus, collected tissues at the time of sinus surgery and pituitary surgeries as controls to see, is there indeed more bacteria in the tissue in disease state versus healthy state? And here's what we saw. So when we cultured for Staph aureus in the middle meatus, patients with CRS, about half or more of them had Staph aureus, whereas in controls, again, half. So when we culture Staph aureus, does that actually mean anything? Often it may actually not. Now, if you look at the amount of bacteria within the tissue in sinusitis patients, you can see that the proportion is quite a lot higher. So what this suggests is that although the culture rate between sinusitis and healthy patients of Staph aureus is basically no different, if we look for bacteria within the tissue and compare disease state versus healthy state, it was very different. So this led us to believe that we certainly do seem to see a lot more bacteria deeper beyond the epithelium in our CRS patients. Are they any different from the planktonic bacteria, though? We did a series of testing basically looking at the genotype and the phenotype. But other than the fact that they're more prevalent, SPA is a Staph aureus type and gene testing where we look at the genome of the bacteria from the surface versus the tissue, and it was the same. AGR gene is a virulence gene. So basically, if it's switched on, it means it's active and virulent. If it's switched off, it's in a more indolent state where it's not virulent and supposed to be more in a calm state. But actually, bacteria on the surface or within the tissue had it all switched on. So other than, and SCVs are called small colony variants, just to say it's a different phenotype that's slow growing and more difficult to kill. But the bottom line take-home message was that the bacteria on the surface and the bacteria in the tissue was the same, which suggests that there's a lot more of it in disease in the deeper tissues than in controls, but it's probably the same bacteria that was on the surface with this epithelial disruption that's made its way into the tissues rather than some sort of a different, more aggressive type within the tissues that's driving the disease. And really, when we see patients like this, where they culture staph, and there's another patient who's culturing staph, do we really think that Staph aureus is the only pathogen that's causing and driving this chronic maxillary sinusitis? And really, I think the answer is no. Yes, sure, we will have Staph aureus, but what we have to remember is these cultures that we do on plates, they're designed to incubate and encourage growth of certain bacteria. And staph grows really well on agar plates. And that doesn't mean that that's the only pathogen. Then came the phase of molecular typing. So we're then talking about beyond culture techniques to look at, okay, what other bacteria are there in the tissues? We did a study comparing the mucus on the surface versus the immediately underlying tissue comparison of microbiota. You would have now seen lots of these taxa plots looking at the different species of bacteria. And this is patient one comparing tissue versus swab, and another patient there, tissue versus swab, fairly similar. And just going ahead with lots of patients, what you're seeing without needing to look at the different names, if you just look at the pictures, that tissue versus swab, fairly similar, but the main thing is that interpersonal variability is so much that the molecular typing of all the bacterial species within a sample doesn't really seem to be giving us much headway in terms of how we treat these patients. So while this was interesting, it hasn't really changed my clinical practice. And then there's, of course, cystic fibrosis patients who are a whole different kettle of fish. You do get a lot of Pseudomonas, but again, is it because they've had so many courses of antibiotics that they grow different bacteria like Pseudomonas? this is an example of a gram stain from tissue that are obtained from a cystic fibrosis patient, and you can see this bacteria scattered through the tissue. So there's certainly a lot of bacteria beyond what we can culture. There's so much more range of bacteria than what we can culture, and that makes the whole microbiology a bit complex. If we then add the odontogenic cause, and you can see in this person, not as dramatic as the patient that they've showed us, but you can see the root of the tooth there is missing, and there's sinusitis. And of course, the bacterial differential changes a bit, where we now get more anaerobes and fungi in there too. And really, I think what we need to talk about from we being surgeons treating these infections is, do we give antibiotics? For an acute sinusitis, there's evidence, by all means, culture directed, etc. That's great. But for a CRS patient, not so much. I mean, yes, if they're having an acute exacerbation of symptoms and more purulence on top of their routine sinonasal symptoms and degree of mucus drainage and postnasal drainage, etc., giving a course of antibiotics, culture directed ideally, can reduce that symptom flare, but it's not going to cure. So in terms of really a curative management, we know that antibiotics is not effective. All of it you would have seen this graph a lot, where we're giving a lot of sinusitis patients antibiotics, and really, what are we doing to them by giving a whole lot of antibiotics when the picture is so muddy? You know, the range of bacteria, the 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 niche. Is it surface? Is it biofilm? Is it within the tissue? How much of whatever we give them is actually going to penetrate into all of these areas? So the complexity of the bacterial niche means that we really should think twice about giving antibiotics, particularly systemic antibiotics, when we're dealing with patients who's having chronic inflammatory sinusitis. Acute sinusitis blip, of course, antibiotics, that's a very reasonable approach, but we deal with a lot of chronic rhinosinusitis patients, obviously. Now, if I shift my focus a little bit from bacteria to fungi, you know, we get the mucor and the invasive fungal sinusitis, but also chronic sinusitis involved with fungal species. And sometimes there might be a role for systemic antifungal therapy, but if we get this sort of allergic fungal sinusitis patients versus a little bit of fungal materials in an odontogenic sinusitis, whether we give antifungals or not will vary. Invasive fungal sinusitis, obviously. But going back to our routine patient of chronic rhinosinusitis, we did a study in our group looking at fungus. Each of these bars represent a patient, and fungal species are what's shown on this taxa plot. So you can see that there's a lot of blue, which is a commensal fungal fungus that I'll talk to you about. But again, you can see that every individual has such varying amount of fungal fungal species living in their sinuses, and this is a healthy control patient, right? So we have all of that fungus in our nose anyway. If we look at CRS patients, it's still the same sort of pattern. So it's not an increase or anything. We've just done it in that order, and we're just seeing a whole lot of different fungus cultured from or identified on molecular typing from individual patients. And between the healthy controls to non-polyp to polyp patients, you can see that the fungal commensals is all about the same. Blue is Malassezia, which is quite a common commensal. So how do we sum it all up? I think the way to sum this up, this is a typical patient or an occasional patient we see, where you can see that they've had extensive sinus surgery, everything looks great, but they've got this fungal maxillary sinusitis. And this is what we're here to discuss. And the answer is, yes, you do try to culture, but actually identifying what's really happening is not very easy. You can give culture-directed systemic or topical antibiotics like Alki talked about, but actually what I do in my practice is give them antiseptics and do betadine in the rinses, because then we don't really there is bacteria, fungus, and a whole lot of different pathogens staying there. And by adding antiseptic, that's less likely to cause resistance and more likely to have broader cover for the different microbiomes that are living in our sinuses. With that, I'll end that talk nice and short. And this is our little plug for a conference we're holding, the Australia-New Zealand Rhinologic Society in lovely Queenstown in New Zealand next year in October. Would welcome everyone here. Thank you. I will see if I can.
Thank you very much.
Thank you very much, Raymond, for an excellent presentation. I think this is an ongoing focus of research that you have contributed so much, and still so many questions to answer. I have one. We have one from the audience. She wants to know what you think about long-term macrolides treatments. What were very fashionable
Yeah.
a
we
long
know
time
that
ago.
there's evidence both from an antibiotic point of view and also from an anti-inflammatory point of view, particularly for the IL-5 driven polyp patients, and certainly we do use that sometimes. And for patients who are more neutrophilic inflammatory types, we might even give them long-term clarithromycin type antibiotic. And yes, there is role for that sort of immune modifying effect. But what it comes down to, I feel, is that we may be reducing bacterial burden, but we're doing it sort of more for an anti-inflammatory effect. Now, for a bacterial infection, sometimes I have given patients long-term antibiotics, whether it's cotrimoxazole or doxycycline, where people are growing staph all the time and very crusty, and giving them a prolonged course of 2 weeks, 4 weeks type antibiotics can control it. But more and more, we're trying to do topical antiseptics rather than systemic antibiotics, because we've done a study in our group where we try to look for the concentration of the doxycycline in the mucus when patients have been given a course. So you give them oral antibiotics and you look at the actual dose that ends up in the mucus. It's so tiny. So we're really bathing patients on systemic antibiotics for a tiny concentration that reaches into the nasal mucosa and the mucus. And if we're talking about surface bacteria, yes, it's better than nothing. And certainly in an acute infection type phase, we would do that. But for a chronic crusting, I just don't feel that there is a role for prolonged systemic antibiotics. So mechanical debridement, topical antiseptics, maybe topical antibiotics is what I would prefer.
I would like to say hello to Luis Fernando Macías. Now we can see him on the screen. Hola, hello, Luis Fernando. Thank you very much for being here. And we'll go on with some questions for Raymond Kim. I don't know if you could listen to the clinical case I presented at the beginning of the presentations. If you have any questions for Raymond Kim, go ahead. I would like to ask you, Raymond, you were talking about the topical antibiotics, but I know so you have done a lot of research about topical different solutions treating biofilms, bacterial biofilms, and I would like to know which ones you use in current practice, and if you use different topical solutions to treat different types of patients or disease. I'm thinking of that crusting that you may have in a patient with a skull-based surgery, with extended surgery, for treating a nasal tumor, and we have like a huge cavity and sometimes getting a lot of pus, and you may use some of these products, but I would like to know which ones you choose in your clinical practice.
So I've done different additives over time. Mupirocin, we've talked about, Bactroban, fusidic acid, gentamicin, vancomycin, have tried a lot of them. But these days I would take a culture, But once the culture has been taken, just so that we know in case there is more of an infective flare-up where I may consider a systemic antibiotic down the line. So that's why I would take the culture. But the topical therapy-wise, I'm using betadine.
Better.
Pretty much universally, because then regardless of what's cultured, because like I alluded to, the whole point about all that microbiology science talk was actually we don't know the microbiology. Yes, we might culture something, but that's not it. And what we front culture from the pus, because that's the more predominant organism, I still think that's useful to know, and that can certainly be a target for systemic therapy. But particularly when we're talking about topical therapies, where we're applying it to the surface, we're trying to soak the tissues in it. That culture I feel is still too narrow and gives me one or two answers, not the whole overall answer, hence the betadine.
Jaime,
Hey, how
want...
are you guys? I have a quick question for Kim. Great presentation. Thank you very much. I've been listening since the very start, even though it's midnight here in Mexico now.
Thank you very much,
1 o'clock in the morning, but a very interesting talks, and thank you very much for the invitation. So I do agree that the need for non-pharmacological topical agents that will eventually take care of microbial issues that we have chronically in the sinuses is probably the way to go from here on. So from some of the initial work coming out of Canada for betadine, have you done any changes to the concentration, and how often are you using it in patients that are you're prescribing betadine rinses for?
Yeah, so betadine we try to do really low concentrations. There's some work that's been done Canada and internationally where there's like a U curve where there's a certain concentration beyond which you're not actually getting any benefit. And actually that therapeutic target is quite a low concentration. There's a company in Australia who's trying to develop a nasal spray form of it, and we're only talking about 0.05% type concentration. So the concentration I use is I get patients to get a 10% aqueous betadine from the pharmacy, and I'm adding 10 ml of it into the sinus rinse. Now, that makes it about 0.04%, 0.05%. Now, patients sometimes actually can't tolerate it because it stings a bit. So I actually get them to start at 5 ml, and it might be once or twice a day. And if they can tolerate it, to add it up to then 6 to 7. And if they can build up to 10 ml, that's the 0.05% concentration that I'm trying to reach. And depending on how crusted they are, they might do that once or twice a day. And I might keep them on it for 2-4 weeks and see them back and see how things are looking.
Perfect. Thank you very much.
Although it gets, you deal with the biofilms, that you still get crusting from the effects the betadine has on the ciliary movements.
Yeah, the whole cilia toxic, but what we have to remember is cilia toxicity is a very sensitive marker for toxicity of the nasal epithelium, right? So when we talk about drugs and potential toxicity, it may not be cytotoxic or really dangerous to cells, but the cilia might freeze for a bit. But if you look at these patients who are crusting, let's not forget those cilia are not working. And trying to do some mechanical debridement and then following up by reducing the microbial load, whatever it might be, bacteria, fungus, I feel is still helpful in those patients. And not to mention we're continuing on with topical steroid therapy for the CRS patients, right?
Please, Jaime, go ahead. I think you had a question.
Yes, first, Raymond, nice to meet you, and thank you for your excellent presentation. I just wanted to know if, given that, as you were saying, sometimes the bacteria is within the mucosa, do you think this reboot approach is removing mechanically the whole mucosa, just leaving raw bone so it can just kind of start again, which is getting...
and Klaus has talked about that, and we're talking about this whole reboot surgery. And look, there's role sometimes, I mean, I find, as you would have all done, that when you're really removing and debriding polypoid tissue, sometimes you end up with some raw bone, right? And once you've got raw bone, and because we know it's going to crust a lot, then we might put some septal free mucosa graft or whatever, and that area seems to do well and better than the rest of the, and I think there is some evidence of that. Personally, I don't then go stripping the entire sinus. I mean, I'm more in the school of trying to keep mucosal preservation as much as possible and to try to debride and to topically treat rather than removing it all. But I mean, I see where they're coming from, and I'm not, you know, against the idea. Whether I would then go stripping the entire sinus mucosa and doing like a, you know, septodermoplasty equivalent for the entire sinuses, I don't know that we need to, or whether I've ever had a case where I felt like that's what was needed to be done.
Okay, perfect. Yes, I wanted to know that, but thank you so much.
Thank you very much, Raymond. Thank you very much to all the attendees that are following this session from very early in the morning here in Europe and other times in the rest of the world. And so let's go with another excellent presentation by Luis Fernando Macías. So thank you again for being here, and it's your go.
Thank you. Thank you very much again for the invitation. And just going to share my screen here. So I think here we go. Pues bueno, antes que nada, yo soy de México y evidentemente hablo español. Lo estamos haciendo así por motivos, obviamente, de la audiencia y de la hora, pero pues le agradezco muchísimo a Jaime, a David, la iniciativa y pues la invitación para estar aquí con ustedes. Hace menos de un año andaba en Madrid en su Congreso Nacional y la verdad es que es fantástico poder volver a compartir, y con todo el gusto, por más de que estemos por acá desvelándonos, y agradeciendo también a mucha gente latinoamericana que se ha conectado para la plática. Going back to the topic and to the language that we planned from the very beginning, the topic that I was assigned, which is something that I really enjoy, not only doing surgery on, but doing a little bit of research and treating on a general basis, is odontogenic sinusitis. So we're going to talk about how different specialties, and particularly our interaction with dental specialists, play a very significant role in terms of how we're actually going to characterize this kind of disease, and then eventually decide on how to treat it. And that's why I named the talk "Timing of Surgery." We should do endoscopic sinus surgery. Is it dental surgery? Is it both, or is it not? So these are my conflicts of interest, none of which will play a significant role for this talk in particular. And some of the objectives that I planned for the talk itself will include some of the classifications that have already been covered in the talks yesterday, particularly by Dr. Macías, and some of the clinical scenarios that we see this disease on, how this has a significant impact on how we manage the disease, and some of the consensus in terms of the type of interventions and the timing of surgery that should be ideal. And we're going to find out, just like Dr. Kim's prior presentation, that most of the time we end up just saying we don't really have enough information to have a direct answer to all of our patients. I'm going to go through some cases and end up with controversies and some take-home points. So first of all, I think then, and this image that can be taken a little bit as a joke, I think it's how we find ourselves whenever we get referred a patient that we suspect will have some sort of dental issue as cause of their sinus symptoms. So I think at the very beginning of it, we like to play the blame game and just to say, well, this is coming from this place or this place, and who should take care of it first. And I think from the perspective that we're all surgeons, we try to make our own and saying, well, I'm going to cure the patient and I'm going to be the one to bring it sort of like to a normal status. But the reality is that throughout the talk, you're going to see that the interaction with other specialties and multidisciplinary management is probably the main focus of treating this disease. The objectives, of course, being the reduction of recurrence, the improvement of quality of life in our patients, and obviously the avoidance of complications, which is one of the things that the case that Dr. Lobo presented earlier in the session sort of like ended up or was a consequence of. So in terms of classifications, and this was mentioned yesterday from the EPOS guideline, we know that odontogenic falls into the category of a secondary CRS with normally a unilateral localized anatomical distribution, and the mechanism is a local pathological alteration. In this case, the abnormal interaction between pathogens that might or microorganisms that might be considered normal within the gum line or the oral cavity that get into the sinus and create a significant disruption of the different mechanisms to try to maintain a homeostasis there. Just like a quick overview, this is something that has obviously been in the scope of rhinologists for quite some time, but the reality is that we've been, I think, looking after it a little bit closer, and it's been probably in the past 8 years that it's been main focus of different meetings and so forth. So what we know in general is that it's normally more common in patients between the age of 40 and 60. There's a slight female predominance. One important thing, and it was touched upon a little bit early in the session, is microbiology is quite distinct from other forms of CRS. And this is important just because we might categorize certain patients in a, let's say, a basket of a recalcitrant type of inflammation or disease, when the reality is that if we don't look for the actual origin of the problem, then we might not be treating that patient adequately. So normally they're polymicrobial with anaerobic bacteria. And it's also important to know that patients that are diagnosed with odontogenic sinusitis and where there's implant playing a role, almost 80% of them will require some sort of surgery. It's independent of its dental, oral surgery, or endoscopic endonasal surgery, or a combination of both. So we now know that we have a significant population that we're working on, and I don't know what the case is in Europe and in New Zealand and Australia, but the reality is that here, at least in Mexico and most of the Latin American countries, is there's been a boom in dental procedures, particularly with implants, and this has become an issue and increased the amount of patients that at least I've gotten to see in my practice in the past, I would say 4 to 5 years. In terms of microbiology, and again, this has been mentioned before, this is a very recent meta-analysis coming out of Beijing, and what they concluded is something that has been published before, but now in a more robust way of having the information. But the reality is that, just as was mentioned before, if you culture or we have a staph aureus predominant infection, the possibility of it coming from a dental origin is quite low. Compare that to having some sort of presence of Fusobacterium, particularly, but Streptococcus and Prevotella, and it's almost certain that there has to be some sort of dental origin for this. And this is important because if we get to culture and we get into the habit of culturing our patients, then we're going to have less amount of errors in categorizing our patients and giving appropriate treatment. In terms of clinical and radiological predictive factors, this is a very interesting paper from Perul Goyal and also from the Stanford group, and you've seen a couple of very world-renowned former fellows from that fellowship, and there's always interesting information coming from Stanford itself, and people that have obviously trained there. What they worked on was what were the predictive factors in unilateral disease to try to figure out if this was coming from a dental origin or not. So you see different aspects of or CT scans where you see an actual dehiscence or where you see a periapical collection, to images that are a little bit confusing in terms of having an actual idea that is from a specific odontogenic origin. So what they found out in this prospective multivariate analysis was that upon nasal endoscopy, having purulence, having a foul smell, which is something that you always have to ask patients, and they almost all the time would come in the office just saying, I have a persistent, very foul smell and a bitter taste to the postnasal drip, accompanied by facial pressure. It has a very high predictive value in terms of the clinical and radiological findings themselves. In terms of factors that can predict people that will need eventually endoscopic sinus surgery when they're diagnosed with ODS, we have this very classical work coming from Verling Ferguson and a couple of other American authors, and what they concluded, and it's something that is obviously still important and still taken in consideration for the for the more recent consensus, is if there's significant osteomeatal complex involvement and dysfunction, that patient is very likely to need some sort of endoscopic sinus surgery. If there is failure with previous dental procedures, then obviously there's something pointing us towards the idea that having only dental procedures is not enough for that patient at that point in time. Having a Lund-Mackay score, so having impact going beyond the maxillary sinus and having higher scores, it's also correlated with people that require sinus surgery. And this is very important because it's also one of the other things that we see a little bit more common is every single patient with retained dental hardware or dental pieces, like you'll see in a couple of examples from my own experience, all required endoscopic sinus surgery. So moving a little bit forward is what are the consensus? What's the recommendation that we can grab from the literature and try to apply to our clinic or to our cases? And for this, I have to make a quick disclosure. The reality is, I think it really comes or some of the recommendations and the flowcharts that you're going to see depend on who the lead author of this papers is. So for instance, in this, the paper published in IFAR in 2020, the lead author was Dr. Craig from Henry Ford's University in the US, who publishes extensively about this pathology. But the reality is, he did a consensus combining dental specialists and ENTs, but I still believe that depending on who has that perspective, will end up having a little bit of a shape in terms of the publication itself. So for this one, what they did was a consensus between all of these specialists, and they came to this conclusion. So first and foremost, using oral antibiotics as type of treatment was not recommended, had no impact in benefit for the patients. Having dental treatment alone in odontogenic sinusitis was almost always reserved for patients with an identifiable dental pathology and with minimal or none or no sinonasal symptoms. And this is very important because I think one of the endpoints, and I'm going to circle back to it towards the end of the lecture, is what we know now in terms of who needs to go first or what needs to be prioritized is something that depends on the patient's symptoms. And this is why this is important in terms of us having a good amount of time to interview the patient and to see what the real problem is at that point in time that we're getting in the picture. In terms of having endoscopic sinus surgery and dental, they decided, or they came to the consensus that FES, or endoscopic sinus surgery, should come as a rescue in failed or unsuccessful primary dental procedures, which is, I think, a little bit controversial, and we can talk about this a little bit later. And in patients with significant or primary sinonasal symptoms with no dental symptoms, endoscopic sinus surgery was preferred as a first procedure. So again, circling back into, if we have a patient that has more dental symptoms than sinonasal with a CT scan with certain characteristics that we're going to talk a little bit later on, it's highly logical to think that they should undergo dental treatment first. And if that fails, then we can circle back and say we need to do something else. And the opposite part of that coin also applies in terms of having someone that is very likely to require some sort of dental manipulation. But if we have a full opacification of the sinus with significant sinonasal symptoms, it's very likely that a certain threshold within the mechanisms of homeostasis inside of the sinus has already come and gone. So having a significant dysbiosis, having a significant amount of inflammatory response in that mucosa will make it almost always impossible for just a dental procedure to take care of things. And we're going to talk about this a little bit later on. In this same publication, in ODS due to maxillary dental implants, they came to a conclusion to try endoscopic sinus surgery to try to preserve the implants. This might come a little bit of a controversy as well, because one might think that any type of hardware that is inside of the alveolar ridge or the maxillary sinus itself is going to become irreversibly colonized by a biofilm or by a persistent bacterial infection. But the reality, and I think in a real world experience, it's a little bit different. The timing between dental and sinonasal procedure was considered between 1 and 2 months between one and the other. And this is something that I do in actual practice. And I'll explain that a little bit later on, but it also has to do with the place that we're going to give the dental or maxillofacial surgeons to actually work in. In terms of the extent of the endoscopic sinus surgery, they did not reach a consensus, and this is something I think also in terms of preferences, and we can see it with a couple of examples that I have for you. Now, this is the other part, or the counterpart of what I mentioned before. So this expert consensus on ODS also involves maxillofacial and dental experts and ENTs, rhinologists, but it's primarily, it's published in a journal of oral science, and it was primarily carried out by a dental specialist. So here you can see that once an odontogenic disease is diagnosed, they start treatment with nasal corticosteroids, irrigation, and oral antibiotics from a period from 2 to 4 weeks. And if that doesn't resolve, then they categorize or divide their patients between people that have symptoms, nasal symptoms improve significantly, in which case they do primarily dental symptoms. Which, when they do this kind of treatment and they don't have symptoms, sinonasal symptoms to improve significantly, that's when they consider having endoscopic procedures done. And you can see here that if they have a tendency or think that they will preserve the dental pieces, then they go ahead and try or ask for evaluation by their rhinologist to do an endoscopic sinus surgery first. However, if that tooth is to be extracted, then they sort of like play with different factors that I think are important in terms of having a continuance in the maxillary sinus floor, or if it's not continuous. And if it's not continuous, they go ahead and do a tooth extraction, which is concurrent with endoscopic sinus surgery. I'm not that for this kind of decision, and I'm going to explain myself a little bit later on, but I just wanted to show what's published out there, because as you can see, there are several pathways and different ways to try to come around and to treat these patients. But I think timing and being conscious about how we're making those decisions are very important in terms of having an adequate impact on resolving our patient's problem quicker rather than later, and trying to preserve dental pieces or trying to preserve implants. So there are a lot of things that are at play around this. I'm going to go through some clinical cases. I still have about 12 minutes to go, and I'm just going to power through them just to give a couple of examples and come back to have a little bit of discussion towards the end. So this first case is a 70-year-old gentleman. You can see that he has several implants, and there's a certain material in there that is used as material to cause the expansion and to do what Alkis was asking for in your case earlier on, in terms of doing a sinus lift or trying to increase the mass of the floor of the maxillary sinus using synthetic material. The reality is that here we need to put in context the timing. So the patient had this implants and the procedures done more than 10 years prior to him presenting to the office with symptoms that consisted of nasal purulence, anterior and posterior nasal discharge, foul smell, nasal obstruction on the left-hand side. So the reality is that this wasn't an issue that happened immediately after the positioning of those implants and the material. It was something that sort of like brewed upon time. And you can see right here that for this patient, even some of this material that used to be in the bottom of that maxillary sinus made its way into the osteomeatal complex. So when I show this images to my residents, I always say it's like the sinus is trying to heal itself, but it comes to that impasse where, because of dysbiosis, because of inflammation, because of mechanical factors, it's no longer able to try to bring that homeostasis. So in this patient in particular, having no dental issues and having no symptoms, we find sort of like the classical image, that is the purulence, the obstruction of the middle meatus, and even a little bit of that demarcation of what the inflammation inside of the sinus is. So I'm just going to fast forward a little bit. This is just medializing the middle turbinate, but you can see a little bit of that foreign material that is used to increase the size of the floor of the maxillary sinus. And I'm just going to move it a little bit forward. And you can see right away that there's material purulence coming out of it, but this porous material that is obviously has been there for more than 10 years and that was causing a significant issue at that point. Again, I try to do my antrostomies and the maxillary approach depending on the needs of the patient. And in general, for patients that have come to this point in their disease, having a small antrostomy is almost always a bad idea, because it's going to close and it's going to give you recurrent issues. And it comes down to a poor surgical technique. It's not recalcitrant disease itself. You need to have a very nice wide opening of that ostium and having an extension, even to the fact of including an MMA or a megantrostomy, just like Alkis mentioned, in cases that are selected. You can also see this papillary type of mucosa that is quite distinct for odontogenic. And this is one of the controversies, and we can touch upon it later on. When I have significant disease that affects frontal and ethmoid, I tend to do a complete type of surgery for this patient. Most of the times that I've restrained myself from doing it, I've almost always regretted it. The fact of the matter is that the infection and the problem started inside of the maxillary sinus, but the reality is that it depends on the patient's immunological response if that inflammation is going to subside quickly enough to avoid any kind of issues to the frontal or the ethmoid. So that's a little bit controversial, but I think if it's chosen adequately, has good results. So that was an endoscopy 3 years after procedure, with no dental procedures done, with no extractions of the implant. So we were able to resolve the sinonasal issue without having to have a secondary treatment or removal of the implants, which, as you probably already know, are quite expensive, or at least here in Mexico, they're quite expensive. So another case in similar conditions, well, you can see the scan with significant also opacification of the frontal, with distortion to the osteomeatal complex, and you can see implants here, and the same issue. So no other periapical issues or problems. It's just a dental implant. But at the time that this patient came to clinic, he had SNOT 22 of 80, no dental symptoms, had already been seen by the implantologist, the dental specialist several times, assuring him that there was no issue with the tooth itself, with several antibiotic courses just because of the opacification of the sinus, and with increased symptoms in the last 6 months, particularly with foul smell and postnasal discharge. Again, at this point in time, we know that we're not going to do any more benefit in doing more courses or more anti-inflammatory treatment to the nose, because we've already reached that threshold, which is a little bit difficult to identify in every patient. But when we see this cavity, it's obvious that we know that this is behaving more like an abscess rather than just a simple sinus infection. And the fact of the microbiology of this has a significant impact on how it behaves. So despite the fact that we have a patient that we treated previously, you can see there that there's significant inflammation, there's swelling, there's bleeding. And just because of the anatomical factors of this patient, and you can see here a very narrow AP for frontal, I do have a low threshold to go and open all of those sinuses that I see that are affected at the point in time that I get to see the patient. So you see almost like a full house on one side, which I don't do regularly for all patients, but I do try to select the patients that I know might become a little bit more complex to treat after the procedure. So patients above a certain age, patients that have a certain history of microbiological issues, and this is sort of like the way that I've been doing things for the past 4 or 5 years. So you can see with a 70-degree scope, the frontal sinus all resolved. This is a couple of years after surgery, and the maxillary sinus coming back to normal with no need of removal of that hardware. And this is a CT scan 3 years after the procedure, and the important here is to see the difference between odontogenic sinusitis and just having mucosal thickening related to dental pieces or to hardware. So this is one of the things that I always put here, because that patient is completely asymptomatic, but you can still see here a little bit of mucosal thickening, particularly where the implant is. The rationale that I take for this patient is, if I have this opening, if I'm able to see inside of the sinus, if the patient is not having relapses in their infection, the reality is that having this opacification here is highly unlikely to cause any issues in the foreseeable future. Another case that is quite dramatic, you can see a significant amount of implants that have been positioned in different fashions in different points of time of this patient's life. And you can see moments where there's clearance. Obviously, this is not a CT scan, which is the ideal way to see this patient, but it helps us sort of like paint a picture of how it behaves. So you can see some opacification of the right maxillary sinus, some foreign material here. Essentially the left max becoming or being perfectly okay, and at certain points in her life having what appeared to be a complete clearance of her right-sided disease. So again, this is important because we get to see these patients in a different time frame and in a very prolonged lifeline of the disease and in a normal progression of the natural history of the disease. So also the time in which we get to see the patient will play a role or will play a role in the decision making at the end of the day. So all of the scans that you saw before obviously were not ordered by me. They were ordered by her max fax surgeon, and at that point in time, she wasn't having any kind of issues with her nose. So when I saw her first, I said, if you're not having any sinonasal symptoms, we can try a nasal spray, and we can continue to follow up. So after about a year or a year and a half after I saw her for the first time, she came in complaining of significant right-sided nasal obstruction, of discharge and foul smell, and I have that CT scan. So again, I'm just going to play it for you guys, and you can see that even on the left-hand side, you can see that there's mucosal thickening and multiple dehiscences of the maxillary sinus floor, even material that has been applied in the past for that sinus lift, but there's no significant inflammation or symptoms on that side. So rounding back or circling back to that classification and the way to approach things, my rationale was to do surgery on that right maxillary sinus because she was having symptoms or sinonasal symptoms in that side. So this is a post-op control. As you can imagine, that maxillary sinus was severely manipulated from below with the implants and everything, and it became contracted quite a bit. But I was able to just preserve a natural opening to that sinus and not having any type of issues post-operatively. And she's been like that for the past 2 or 3 years. Coming to the final cases in terms of the absolute indications for surgery, you can see here an attempted implant application, and this poor woman coming from Puerto Vallarta, if you know some of the beaches in Mexico, she had a procedure that she described as brutal. That was her words. It was very traumatic. There was a lot of pain. There was bleeding. It was all done in office, and you can see here very clearly that the implantologist here tried to do an incision and an implant and to apply that buttress or the first part of where the implant is fixated on, and he lost that implant inside the maxillary sinus, did not say anything to the patient, and then proceeded to do another implantation a little bit posterior to that. So needless to say, this patient started having sinonasal symptoms that never had before. And the importance here is that this patient, despite the fact that there appears to be a dehiscence here and that there were no symptoms, significant symptoms with the implants, sinus surgery was needed definitely to remove that foreign object. And this is how it appears: multiple antibiotic courses before, this papillary aspect of the mucosa that is quite distinctive or pathognomonic, and you can see the metallic material inside of the sinus. So obviously, if we don't do an adequate surgery and remove this kind of hardware, it's impossible to have a full resolution of the symptoms of the problem that this patient is experiencing. So this is a couple of years out, and you can see that I also did frontal surgery for her just because of the intensity of the inflammation inside of her sinus, and you can see the maxillary sinus completely open, and you can almost get a glance of that posterior implant that was kept in place and did not have to come out. This is a case that I did last week with one of my colleagues, and I shared it on social media. And it also comes to see that it's not only implants or stuff that is causing issues. It's procedures as simple or routinary that might be a third molar extraction. So you can see the CT scan. This patient had a third molar attempted extraction on that side 7 years ago, and the whole molar went into the sinus itself, and she was asymptomatic for 5 years. And she started having significant pain, purulence, discharge, to the point that we needed to get her in hospital to have IV antibiotics to reduce swelling, to prevent any type of inflammation or complication from the sinusitis, and then proceeded to do the surgery. And you can see there the full molar inside of the sinus. So here, obviously, there's not much debate in terms of if we needed to do the surgery inside of the nose or not. Probably the debate would be if there was any issue to the apparent dehiscence to the bottom of the maxillary sinus, but the procedure was done 5 years prior, and there was no active oroantral fistula. So the reality is that, despite the fact that we did surgery on this patient last week, I'm very sure that she's going to do exceptionally well just by doing what we did last week. So some final thoughts, and just finishing with the final 2 minutes that I have. This is a patient that I did surgery about 2 or 3 months ago. And while I was explaining all of the consensus, and if the dentist that referred the patient to me had to go first, or if there was something to be done to the remaining molar that was there that was not removed adequately. You can see that there's a partial resection of that molar piece. There's a dehiscence of what appears to be a periapical infection. When I explained the whole thing, he told me, "You know what, doc? I'm an architect, and or how you're explaining things is very similar to what I look for when I'm supervising construction." And the reality is that if you don't have an adequate foundation for anything that you're going to do to try to rebuild that, it is bound to not work. So I've been using this metaphor for the past 3 months, and I've done probably about 2 or 3 cases a month of this kind of issue. But the reality is, having this as some sort of a mental image, in this case in particular, despite the fact that this patient had a specific dental issue that was asymptomatic at the time, if I'm not able to take care of the inflammation and dysbiosis that is causing an issue in that area, which is the foundation for whatever reconstruction the max fax or the implantologist is going to do, is very likely to fail. So this was his maxillary sinus on that side, significant inflammation and the papillary edema that Dr. Craig described. And this is him 2 months after the surgery. Also, and as I mentioned, you can't see that from the CT scan, but he had some involvement to the frontal sinus. So I do extend my surgery a little bit more. And you can see that the swelling has subsided almost completely within 2 months. And at this point in time, I'm free to say you can go to your dentist and they can try to do whatever they feel they need to do with this dental piece. And the reason that I'm showing this case is I tend to show certain examples of interesting cases on my social media, particularly on Instagram. And I got several responses from people, and if I'm not mistaken, even from some colleagues of you in Spain, saying, "Why are you doing surgery for this patient if there is very clearly a problem going on here with the tooth?" And I've had experiences that person mentioned that just taking care of the tooth, you can take care of the sinuses and you don't need to do anything. But the reality is, just looking on this case retrospectively and looking at what the sinus looked on the inside and the symptoms that the patient had, I find it very hard to believe that just by doing some sort of procedure to the sinus, to the root or to the dental piece, you're going to be able to reverse everything that has happened to the sinus itself. So just to conclude, and some take-home points, you can see here that there are no specific indications for every patient, and we do have to learn to play with others. And I think we as rhinologists within ENT have learned to play with other specialties for quite a while. So having your neurosurgeon on board, your oculoplastic surgeon on board, having your oncologist, your head and neck on board is important to have your dentist or max fax on board to try to work with people that think alike. Another thing that is what became a big piece of advice for myself was to try to figure out if you're working with the right people, not because of just like affinity or if it's the same center that you're working in, but if they have specific knowledge, particularly of periodontal disease. It's not something that everyone gets trained in dentistry or in MaxFax. So being able to do a pulp test or being able to do a viability test for different dental pieces is crucial for decision making. So surrounding yourself by adequate specialists is very important. What I now do, and you saw throughout the presentation, is I do follow a symptom-based decision algorithm for my surgical treatment. And I think so far it's been quite okay to take care of my patient's pathology and not have significant relapses or problems. There's still controversial topics in terms of the extent of surgery, the removal of the material because of what I mentioned before in terms of potential biofilm, and what's the role for concurrent dental and endoscopic surgery for certain patients. If you ask me, I still have this analogy from my architect patients in saying, I can't really be sure that if I do the sinonasal surgery and at the same time my dental colleague does some sort of extraction, reconstruction of an oral fistula or manipulation, it's going to have the same exact rate of success compared to if I'm able to control most of the swelling and the dysbiosis that is happening in that maxillary sinus for them to work afterwards. But it's still something that is a little bit controversial and it's on the works. So again, thank you very much. Muchísimas gracias por su atención. Gracias a los que se conectaron en este uso horario por acá en el continente americano y a todos mis colegas en España. Les agradezco de nuevo la invitación y pues quedo a sus órdenes para cualquier duda o pregunta.
Muchas gracias, Luis Fernando. Thank you very much for an excellent presentation. I really like it. I think we learned a lot. While we are reaching now to the end of this session, I would like to sum up some of the conclusions that some things we have learned in this session today. I think one is the importance of the growing cultures for testing the fungi or bacteria, and so lead better treatments, antibiotic treatments for this disease, especially in those potential complicated patients that may develop more issues. Another aspect that I want to highlight is this last presentation, Luis Fernando Macías, the timing between dental surgery and sinus surgery, that you may follow the symptoms of the patients, but whereas you choose the sinus surgery first or dental surgery first, what it's really important is that you have a very good relationship with your dental colleagues. So they prompt you, they seek your prompt diagnosis, and you can also refer the patients to them for dental evaluation. And also I want to highlight apart from the IV or oral therapy, in those complicated patients, we also have a topical therapy that we can use to treat recalcitrant crusting and disease, and also to think about all the different surgical approaches, depending on the severity of the disease of the patient. we may go from simple antrostomy to different extended approaches, as Alkis Psaltis sum up so excellent in his presentation. I would like to ask you now a question, Luis Fernando, and I give also Jaime and Raymond Kim time to make last comments or ask questions to you for your presentation. I would like to know when the dental procedure may imply a fistula leak. Do you go for and treat everything at the same time, or do you go for surgery and after maybe antibiotics and therapy go for closure? Would you do it at the same time?
Yeah, so that's a great question, and is one of the questions that is almost always brought up in the panels or the collaborations with other specialists. I think it comes down to timing. So if the oriental fistula is identified very early on, and there has not been enough time for a significant inflammatory reaction to the sinuses, I think primary closure of that without having to do anything endonasally is quite a good option. And it might even just to prevent any kind of sinonasal problems along the way. It might not be 100% preventive, but I think it significantly improves things. There's also literature in terms of the size of the oral-antral fistula to take in consideration. So we know that when the oral-antral fistula is larger than 5 to 6 millimeters, the chances of it closing on its own are quite small. So something closer to 1 centimeter is always something that needs to be taken in consideration when deciding surgical procedure. Another thing that is important, and I think it always becomes a little bit of a confusion because you get these referrals that way, is that whenever they see adhesions on the maxillary sinus floor, even if the person that refers the patient has not done a sort of like a full examination of the patient, they always mention it as an oral-antral fistula. And we still have to remember our lessons from medical school in saying a fistula is a communication, an abnormal communication between two cavities. So when we see the scan, we can see if there's a full-on communication through the mucosa and the bone. Sometimes it's very small, and the patient is able to identify it by blowing their nose or by having some sort of discharge coming out of there. But the reality is that most of the time, just like that final case that I showed with the molar inside of the sinus, all of the time it was referred as an oral-antral fistula, and the reality is that there was no fistula whatsoever. That patient had that closed by a mucosa without any intervention, and that was done independently. So the reality of that timing comes to when you get to see the patient. My issue is when you get that referral with the patient with an active or an open oral-antral fistula, and there is significant opacification of the sinus with symptoms, I would almost always tell my max fact or dental colleague that I'd rather do the sinonasal part first, allow it for a couple of months to control the inflammation inside of the sinus, for them to come in a second time and do the closure if it's needed. The reality is that I've done this several times, and I would say around 80% of the time, despite the fact that you can find pretty large adhesions, you can get a significant amount of closure from the healing process of the patient itself. So it becomes easier for the person that is doing the reconstruction afterwards, rather than just saying, well, it's better because we can do it at the same surgical time and we're going to save time, or it's just one anesthetic. The reality is that I think you can, if you think it the other way around, you're preventing certain procedures to be done in patients that might not need it at the end.
I completely agree. I think we have to see this like a two-way path. So yeah, dental infections or causes potential damage in the maxillary sinus, but it also goes the other way around. So you clear all the secretions, and then you help for the dental procedure not to be done and to have better outcomes, I think, in the end. So yeah, I really agree. Raymond, do you want to ask any questions?
Thank you for a great comprehensive talk, and there's no sort of further comments or questions. That was great.
So do you want... Sorry, Jaime, go ahead.
No, actually, my question was similar than yours. I was wanted to hear about not just the fistula, but more about the hystensis, because it's more controversial. You know, the fistula, you have to close it, but what would you do with that? So yeah, basically, I agree in most of you were saying. I've tried myself many different approaches, doing one thing first, doing dental extraction before, and I think I've had all kind of results. But at the end, they tend to heal, and the patient tend to improve or do whatever you do. Basically, you have to know where the infection is coming and how the extension in the sinuses is. So if the disease reaches the osteomeatal complex, you have to do surgical treatment there. How extended the surgery should be. I've tried different approaches too, and I also like to do full fast in that case, but I've tried doing smaller surgeries, and it also work. If you heal the maxillary sinus, and you just remove the anterior ethmoid and then ventilate the osteomeatal complex, at the end, the whole sinuses of that size are going to heal. So basically, it's a good surgery and good problem, because I mean, in many different approaches, you're gonna reach good results. But it's very interesting to see what's the literature and your opinion. So thank you so much, Luis. I know it's you're struggling now with the time, and you have a big surgery tomorrow. I know that.
Raymond,
Thank you very much.
Raymond, do you want to share any final comments? Do you want to give final advice for treating recalcitrant infections, the maxillary sinuses, those sometimes terrible cases, all ladies or men we see sometimes with what they've been treated many times when they came to us and they have this maxillary sinuses operated several times and that keep having infections. So we know now about extended approaches and also treating with antibiotics. We have cultures to select the better therapy. But any final comments? Yes.
Look, I think it's just the combination of good surgery, right? And good debridement. And, don't be shy away to go really expressing and squeeze out the edema and debriding the crust and scab away, get rid of diseased mucosa, good topical therapies. And sometimes it takes another visit to the operatorium to really scrape down all that debris, and you just have to really get surgically good opening, macroscopic disease clearance, and then topical cares. More final comments.
Thank you so much, Raymond. Thank
Fernando.
you, Luis, David.
Thank you.
I think creo que ya estamos en hora, David, ¿te parece?
Yes, I just want to thank again Raymond, Luis Fernando, and Alkis who had to leave earlier for being here and for sharing all their knowledge to us, to the attendance. Also, I want to thank all the people who have connected today. And I give the word to Jaime, who wants to present next session for tomorrow. That is going to be fantastic, I imagine.
Yes. Así que bueno, ahora en español, con permiso de Raymond, mañana vamos a tener unas sesiones muy interesantes, moderadas por mi colega, amigo, que ya conocerán mucha gente de Latinoamérica, el doctor Javier Ospina de Colombia. Va a ser una sesión un día sobre tumores nasosinusales con el doctor Arif Janjua, que es tanto su mentor como mi mentor del hospital del Vancouver General Hospital en British Columbia, en Canadá. Y luego el profesor Ian Wittery también va a hablar del manejo de los tumores de base de cráneo. O sea que va a ser, esta vez será por la tarde aquí en España, será una sesión súper interesante y espero volverles a ver a todos. Así que nada, muchísimas gracias otra vez, Luis, thank you, Raymond.
Thank you very much.
Bye.
Bye.
Gracias.
Adiós. Gracias, Luis.
Hasta luego, que estén bien. Gracias.